this is something that I hear as an optometrist quite a bit. I think the old MD versus OD just kind of butting heads, almost territorial, where FLACS, so femtosecond laser-assisted cataract surgery, doesn't provide any benefit over manual cataract surgery. I think in the optometry world, I hear that quite a bit. And in the refractive world, now that I've always been on the other side, I've worked in refractive surgery my entire career, I see it a different way. I'm curious what you guys think. Anybody want to take this one?
I'll go first.
Josh, go for it.
I kind of come from an interesting standpoint in the fact that before I was at Williamson, I was at a much older surgery center, gosh, probably about a decade ago. And they did very little FLACS. They did very little, fancy cataract surgery, very few multifocals and all that. And so I got to see all the post-ops there, everything done by hand, all that good stuff. And then Williamson, where I'm at now and have been for a while, we've got all the fancy stuff. And I mean, what I see, just clinically, I don't know the studies or anything like that, just what I see in my chair, I find that the patients tend to be happier faster. The target seems to be closer to the goal, and they seem to heal up faster. That's just clinically what I see. So, and when I hear it explained to patients, like, yeah, we can do everything by hand, it's a great surgery, or we can use lasers to really assist us and do a lot of this work. We're in the eye a little bit shorter time, all that good stuff. Everything seems to be more accurate. It makes sense to the patients. And now that I'm on this side, I almost feel bad for the patients that weren't offered the FLACS.
If I could add to that, I have had a similar experience in that when our practice first started, we were using a surgery center at a hospital until our surgery center was built, and we didn't have FLACS. And when we opened our surgery center, we installed a system, and the speed with which patients were recovering, the decrease in inflammation, the accuracy of our toric placements, it just increased. It was actually a wow. Like when we got our surgery center opened and we started doing that, I literally walked up to Dr. Strange and I said, "This is pretty amazing. These people look different on day one after surgery than what we were doing before." And our, I can't, just the toric placement and stuff like that. It's amazing. So I saw the difference in the outcome. And I just had a patient recently going, "Hey, I did some research and they said that this laser assisted isn't any better than manual." And I, we sat and talked about it for a while. And I said, I tend to disagree. And to Josh's point, I always tell patients the human eye doesn't like to be messed with. Get in, do what you have to do, and get out. And if FLACS allows us to get out faster, we have better recovery. So I've had a very similar experience. I can't imagine, we offer it. Everybody gets offered that.
Neil, what about you? What do you think?
Yeah. So I think, my perspective is, I think this is absolutely a myth. I think the issue we run into where this myth kind of comes from is, I think in general, we've gotten really good at cataract surgery as kind of as a group, right? Not only as our surgical training gets better, volumes, we all get, do more surgery, but also just phaco technology, right? We have machines are great, chambers are stable, we have all these fancy other tools when we have dense lenses. So we have, so now when you're starting to see, okay, what's the benefit of an added technology? You're working in really slim margins, right? So, we look at data, for example, right? And it's hard to prove statistical significance for something that's going to be a very small change. But that being said, a small statistical change doesn't mean it's not a real clinical benefit. And you guys are seeing that in the clinic, right? When you see these patients in post-op, they look cleaner. I think when I talk to my patients, I always say, hey, look, we offer laser-assisted cataract surgery. It's laser-assisted, so 80% of the surgery is still done by me manually, but this helps me with a couple of really important parts. If it was free, I do it for everybody. It's not free, and so there's a cost component of that, and that always goes into the patient's cost-benefit analysis. And then I go into, okay, in their particular case, are there things in their particular case where I think that cost-benefit weighs more heavily in their favor? So certainly premium IOLs, where you want that nicely perfect, round-centered rexus, or toric alignment is great, especially if you're working in between toric powers, right? It's nice to be able to do a little LRI to really knock down that astigmatism and line up the toric IOL to those arcuates. That's super helpful in the OR. And then, think about, dense lenses and patients with Fuchs and all the other sort of peripheral cases where there's, getting in and out faster is going to be better for the patient long term. And so I think when you look at those cases, it's not every case that you're going to talk about, but that doesn't mean that every case can't benefit from it.
Great point. I mean, that's I think great point. I tell patients that all the time too. I mean, if it were free, we'd do it all the time.
Yeah.
Now, when you're trying to, there's really no such thing as a non-refractive cataract surgery nowadays. Everybody comes in with some expectation. And, there's advantages. There's several different advantages with femtosecond. Number one, it's going to make the healing process, like you guys all said, it's going to make it quicker. These patients are happier faster, and our patients are extremely impatient too. So getting them happier faster, that makes my job a lot easier. Awesome. But then, cylinder. I mean, astigmatism. We can manage astigmatism at a lower level. Would you ever treat 0.75 diopters in a contact lens? Josh, you're the contact lens guy. I mean, would you put that in a contact lens?
Pretty rare occasionally. Very, 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 very rarely.
Well, you could. I mean, you could also do that with cataract surgery nowadays too, or a diopter. Toric lenses sometimes, a diopter is kind of where they start. So we can treat that and much more accurately. So we use the LensR system, the Ally system in our clinic, and we love it. I think a big part of the Ally system that's so great is it does have iris capture. So you can actually look at the crypts on the iris. So when patients lay down and they cycle or rotate, it can fixate on that landmark and be much more accurate, which is super, super cool. Not only that, but the toric markers. Neil, you mentioned the toric markers. We can now manipulate our toric lenses to line up exactly where they're supposed to be. It also kind of holds us accountable for our co-managing doctors. They can now see where that lens is supposed to be, and they can see if it's not lined up. And lenses can rotate. That is something that happens maybe 3% of the time. So that's just an advantage, again, to keep us all on the same team. Do any of you guys use femtosecond with the LAL? Speaking of toric and astigmatism management.
Yes, with all LALs we do.
Okay.
It's great to help debulk. It allows us, because the LAL has a certain amount of cylinder it can do and whatnot. So it helps us to debulk the cylinder down a little bit, which leaves us more room to adjust and manage.
What's your threshold? Like, where do you consider doing an AK?
We actually will use it, anywhere, but our threshold with the LAL is, we don't go over 275 too often. A lot of folks do more than that. I'm a little conservative on that. As far as SIL goes.
Josh, Neil, do you guys have a threshold where you will or won't do an AK?
Yeah, around 3. If I'm 250 to 3, I'll throw in an AK, either femto. I don't do a ton of femto with my LALs, and that's mainly a cost issue because we don't own our femto, and so that cost starts to add up pretty quickly to the patient. But a manual LRI in those cases, and actually it works pretty well actually.
Okay. Josh, anything there?
That's above my pay grade. That's a Blake Williamson question, to be completely honest with you. But
totally fair.
I do want to just really emphasize that I get asked all the time by my patients, whether it's a friend or a family or just they've learned about all their options for cataract surgery, and they just ask me, what do I think? And one of the most popular questions they like to ask me is, what would I do? What would I recommend for my mother, my father? And without question, I would recommend femto. So I think that, letting patients know that, because it's true. I think there's something very powerful for that.
Yeah, I think in the optometry world, especially, and maybe it's a generational thing, but sometimes it's thought of as a money grab. These greedy surgeons just want the money. But I mean, if you ask any surgeon, and surgeons, Neil, I mean, you're a surgeon. I mean, surgeons tend to be pretty confident in their skills, as you should be. You're very talented people. So asking a surgeon, would you take a very important part of this procedure and use a laser to do it? Almost all surgeons that I would ask probably would have the laser do their own surgery, right? I mean, would you want the laser done for your surgery, Neil?
I agree. I agree. It's like, to your point, I mean, there's a lot of lot of really, really great surgeons that I would happily trust to do my cataract surgery. But if I have the access to the tool that takes that part out of the equation, I mean, certainly there's no downside.